the higher your risks are, probably the more seriously you should take getting these vaccines that can help prevent respiratory infection. It's really important to have a conversation with your primary care provider or your respiratory specialist or your immunologist to determine how important it is for you to receive these vaccines.
Welcome to the Expand podcast, where we unlock the secrets of respiratory health for healthcare professionals. Join leading experts as we dive into chronic lung diseases and expand your practice.
Today we have Dr. Ellis talking to us. She's an allergist, immunologist. We are going to discuss on the topic of the immune system, immunodeficiency, a chronic condition that might be associated, and also certain treatment. This is important because it's going to be discussed in the context of COVID and increased risk, especially for the complication of COVID. What can we do to prevent COVID and needed for treatment, and which population is at high risk of COVID, and especially complication such as hospitalization and an increased risk of mortality. Ellis is a professor in the Department of Medicine at Queen University in Kingston, Ontario. She's the chair of the Division of Allergy, Immunology in the Department of Medicine. Dr. Ellis also runs regular allergy and immunology clinics out of the Hôtel-Dieu Hospital, providing clinical assessment of allergic rhinitis, asthma, food allergy, anaphylaxis, drug allergy, stinging insect allergy, urticaria, and eczema, in addition to immunodeficiency and other immune disorders. Welcome, Dr. Ellis. This is a real pleasure that we can have you and have a chance to discuss about some important issue related to COVID and a patient that are immunocompromised and also patients that have chronic disease. Maybe we can start with kind of the beginning to make sure that our audience has the same understanding. Everything seems to be managed by the immune system. What is the basic issue that we have to know and the population have to know about the immune system?
So, in very general terms, to start, our immune system is our various lines of defenses to stop us from becoming infected. So, we have early barriers, even simple things like mucus in your nose that can help trap viruses so that you don't even get exposed to them in the first place at the next level down. But then we have simple immune responses that are very what we call innate, that can basically look after almost 95% of fighting off infection. When you think about immunology and when we talk about fancy immunodeficiency, immunocompromised, now we get more into the nitty-gritty of what are the kinds of things that make certain people specifically prone to certain types of infection. But really, the immune system's job is to try to prevent you from getting infected, period.
Thank you very much. But we use terms sometimes, and we're going to use these terms probably in the discussion. We're talking of immunocompromised, we're talking of immunodeficiency or immunosuppress. All these terms the same, or what are we referring to here?
That's a really good distinction, because people can be immunocompromised in temporary circumstances. So they have to take a course of, say, corticosteroids, which can temporarily suppress your immune system. You usually can recover from that very easily. If you are somebody who actually has an immunodeficiency, that tends to be something that you don't get away from very quickly. And so therefore, you're more likely to be at risk for infections for longer term. And immunosuppressed, sort of similar to immunocompromised, but it's really important to recognize that some of the medications that patients wind up on, where the pharmacist may warn you this could suppress your immune system, there's varying degrees to what is meant by that. Some of them are very mildly immunosuppressive, some of them are more potently immunosuppressive or a bigger concern than others. So it is really important to speak with your pharmacist and your doctor to get a better sense of what's my actual risk of immunocompromise or suppression. Immunodeficient is kind of something you're usually either born with or we have recognized as something that's never going to go away. So there is definitely nuances and differences, and especially if you're under the care of an immunologist, they can help you figure out what category you fall into.
That's very interesting. That would mean that if I was a patient, I would probably know if I have a disease that is recognized to be immunodeficiency, and therefore which there is a primary dysfunction and so on, where there are certain disease that might be at a different degree, maybe some chronic disease, and there are certain medication that can make you deficient temporarily, and that's obviously where things are very complex and patients need to know from their healthcare professional in which group they are.
Absolutely. Again, the occasional course of prednisone or corticosteroids, that's a very temporary, mild suppression of the immune system, whereas there are certain biologics we use to treat chronic inflammatory diseases like rheumatoid arthritis or inflammatory bowel disease, where it's a bit more of a bigger hit to your immune system, again, temporarily. And then there are people, as you alluded to, what we call primary immunodeficiency. You were born with it and you've always been at risk for recurrent infections. And we need to get on top of those types of patients even more aggressively than the people who are at temporary risks.
That's interesting. Then I guess what the population has to understand is that if you are with the virus, and we're going to talk about COVID, then the risk that you can develop the infection and the risk of having complication from that infection would also vary quite a bit in relation to certain factor. What are these factors that we should consider in population that are at higher risk of COVID and higher risk of COVID complication?
So definitely, if you fall into that primary immunodeficiency category, as in you were born with a problem with your immune system, you're at much higher risk than patients who wind up on prednisone more often than the average person, where you have that's sort of what we call a secondary immunodeficiency, tends to be milder. It's much less of a risk than the people who actually have an underlying problem with their immune system. And it depends a lot on what else is wrong with you. So, are you taking prednisone from time to time because you have asthma? We know now, with extra years of experience with COVID, that asthma actually is not a higher risk for COVID infection severity. Whereas, and I know I'm already jumping the gun, but if you have something like chronic obstructive pulmonary disease, or you have other issues, right? So you have heart disease, you have diabetes, you have obesity, the more health problems you have, the more that little bit of hit to the immune system from things like steroids can then have a bigger building impact.
Yeah, and that's we've learned over time that certain disease make you at higher risk of having the infection, where other disease may not make you at higher risk of having the infection, but higher risk of having the complication requiring an hospitalization, or even to the point that it can increase the risk of mortality. You've been talking a lot about those comorbidity that we often see, like chronic respiratory disease such as COPD, as you mentioned, cardiac disease also, patients that have chronic renal failure, but obviously patients that may have cancer also, especially if these cancer are treated with a chemotherapy. Transplant patient obviously would be a group also, or any condition with where people are born or have an acquired immunodeficiency. But what about age? Because when we remember kind of the time where at the beginning of COVID and even now, age seems to be a factor also. What do we know about age, and do we know that if it's related to the immune system or not?
And absolutely. So age is known to be an independent risk factor, and it is related to what we used to call immunosenescence,
Okay.
which basically means your immune system does tend to get weaker the older you get. It's a natural progression of what happens with your immune system. So we think, the universal we, think that's contributing to why age could be a potential additional risk factor for more severe outcomes with COVID-19, or in fact, any respiratory infection.
Well, we know that COVID is very contagious, and that's obviously there are certain precaution to take, trying to avoid the exposure. It's not always possible that you have to know that you have COVID, then you can try to avoid to go outside and make other people at risk. But is there a notion of the load of the virus and the time of exposure that is an important as well? If I'm walking on the street and I don't have my mask to say something, as opposed to if I'm in a crowd of people for an hour, would that really matter?
So that's one thing that has emerged as being quite important. And I've learned from my infectious diseases colleagues that the burden of exposure is very important. So, and the things you'd think wouldn't make as much of a difference actually are critically important. So, washing your hands
Hmm.
properly, working very diligently to train yourself to not touch your face. Masks have a bit of a role as well. But honestly, all the ID people I talk to say, wash your hands, wash your hands, wash your hands, don't touch your face. And then masks are another nice thing to do. Um, and again, I think masks are important for the people who are not yet aware that they have the infection. And this is related to not just COVID, but other respiratory viruses. If you're still in that asymptomatic phase, masks are better to stop you from giving it to other people than the reverse. So they're better at stopping you from giving it to other people than it is about stopping you from getting it. Because most of us don't wear goggles or the
Yeah.
face masks or anything else like that out in public. But again, like I say, my ID colleagues are like, actually, no, washing your hands and not touching your face, and don't shake hands, that kind of thing, that actually goes much further than you would ever imagine than compared to a mask. But masks have an important role as well. But one of the things I've learned as somebody who suffers from allergies, and I always have itchy eyes, it's
Yeah.
been very hard for me to not rub my eyes. But I've learned not to. It's like any other habit. Eventually you can break it.
Yeah, and that's I think that rule that you're putting forward is very important. We don't realize. In fact, if we're sick, we should stay at home as much as it is
Mhm.
possible. And if we have symptoms of respiratory viral infection, very often we don't know if it's COVID, but it could be other type of respiratory virus. Could be flu, could be rhinovirus, RSV, even an adult. Then we should think about protecting other people in a way that,
Mhm.
especially the elderly and especially people that we know that may have uh, immunodeficiency, and or people that have a chronic condition, as you mentioned earlier on. What is when people get infected with COVID-19? What is there a relationship with the complication after the COVID? Because we've been talking about this condition called long COVID. Do we know if that, obviously if we don't catch the virus, then we have a zero chance of having that condition. It's after catching the COVID. But do we know if there is any relationship with the immune system, with the severity of the COVID, or even treatment, using vaccine or having a treatment for COVID will reduce the risk of long COVID, that condition that persists after you had the infection.
So long COVID is something we're just slowly but starting to scratch the surface of to try to understand who's at higher risk for it, what can be done to prevent it. This is the one circumstance where I'm now seeing some more issues in my practice because I tend to treat more asthmatics than I treat COPD patients. And it's definitely, I think I just want to emphasize to the listeners that it is a real thing. And some patients are debilitated for up to 6 months after contracting COVID-19. So there is definitely a role, I think, for early treatment if you can happen to identify it earlier. Everybody I've seen with long COVID did not receive antiretrovirals, or granted, the monoclonal antibodies don't seem to have made a lot of traction with the changes to all the different mutations to this virus, and they're harder to get access to. But I do think the earlier you can recognize that it's actually COVID and jump on top of it for treatments, or at least take care of yourself and don't try to push through it and keep doing what you normally do. That's what I've seen, are the people who think, oh, I'll just wear a mask and go do what I need to do anyway. That's been an issue for long COVID. We still need to do more research in this area for sure, because that's where you see the long-term consequences. I realize this is a respiratory talk, but I've now seen at least 6 cases of chronic spontaneous urticaria have arisen post COVID-19 vaccination. So, sorry, not vaccination, but infection. I've seen a couple with the vaccine too, but the important thing is that being infected with COVID-19 can trigger chronic hives. So it's clearly a potent virus that can cause a lot of long-term complications. So everything we can do for prevention and early treatment, if appropriate. We realize that things like Paxlovid, there's a lot of drug-drug interactions, and we may not be able to find the disease fast enough, and or you may have other reasons why you can't take those medications. But it's worth thinking about every time you get symptoms of a cold. If you can get access to a test, which I also realize is becoming more and more challenging now, but if you can get access or are willing to pay for it, it may change your outcomes if you know what it is exactly you're infected with.
Yeah, but thanks for this information. I agree with you that we still have a lot that we don't know about, and even preventing long COVID, it still remain in the unknown. And obviously, if we have someone that is can have vaccine with to prevent the condition for complication, although we still don't know vaccine would prevent long COVID, but the treatment might be certainly a way to go, especially if you end up to have a severe condition like bring you to the hospital. And talking of complication, let's come back to the population at risk, because I think at the end of the day, what people should know is if they are in the group of patient at risk, and we've been talking about patients that have immunodeficiency, and that could be temporary for some because of the medication they're on, some other because they have a condition that require to be on an immunosuppressive treatment. I like your example of differentiating. For example, you take prednisone for 2 weeks for an acute episode of an asthma attack, as opposed to you have a rheumatoid disease and you have to be on a kind of a biological and immunosuppressive treatment for a long time, that you're not the same risk. But we have seen comorbidity, that patient coming, as we said earlier on, with diabetes, with cardiovascular disease, with chronic airway disease such as COPD, chronic kidney condition as well. Okay, and these people are at higher risk of being hospitalized and even had a higher risk of mortality. Do we understand what happened to these people, why they are at higher risk, and maybe after we can discuss what should be done differently in these people from compared to the general population? But do we know why these people are at higher risk?
So first and foremost, it's great that you're re-emphasizing these risk factors for more severe disease. It's not just because you have a chronic lung condition. Chronic disease of any kind that you're never going to recover from, like diabetes or heart disease or chronic kidney failure. And to your point, when you brought up cancer patients or renal transplant patients who are on even more potent suppressive immunotherapies, unfortunately, we just know these are people at higher risk, and we can't really take that away.
Mm-hmm.
But it's important that we completely and always recognize that these types of, including obesity as well,
Yeah.
are things we need to pay more attention to. Um, the magic reason why any chronic disease takes a chronic toll on the immune system to varying degrees. When we think about cardiovascular disease, it's an inflammatory disease. We're increasingly recognizing that obesity and diabetes, there's a degree of inflammation. That's the wrong kind of inflammation. So it's not promoting the right arm of your immune system to help you fight infections. And it's, again, a complicated thing to get into in this level of an information session. But anybody who's got these chronic diseases has a minor hit to their immune system that helps to, and a lot of people who have one of those conditions that you've already named tend to have another. So then it becomes more cumulative. The mechanisms and the exact pathways have not been fully elucidated. It's certainly not to the level that I have expertise at. But I think it's just important to realize that all of those hits are important things to consider, and to recognize that if you have 3 or more of those conditions, you're going to be at higher risk for more severe disease, and all the reasons to take more precautions and actually try to get early diagnosis and possibly treatment if appropriate as you move forward to try to prevent the long-term complications.
Yeah, I think the message that you're giving is very important for the population, and age is a consideration. Having certain chronic condition and being on certain medication or certain condition that are well known to be associated, okay, with immunodeficiency. But there is no such thing always as a bottom on and off, where you have it, your immune system is 100%, or your immune system is 0. And in between, there are a lot of chronic condition where we know that these people, by the type of inflammation that they have, as you said, the wrong inflammation, these people have some immunodeficiency, and they're probably at higher risk of complication because of that. Talking of complication of COVID. Oh, sorry.
Yeah,
Go
it's a
ahead, Dr.
curve.
Ellis. Yeah. Please.
So it's a
Yeah.
curve, right? So if you're one of these younger kids who have the really rare, severe combined immunodeficiency, that's like 0 immunity, right? And then everything else is on a spectrum. And as I said, like every little thing you do to yourself, like that you wind up developing, could be that next hit. That where it becomes important to take at consideration all of the things that you may or may not suffer from as an individual, rather than looking at just one thing. And it's important to realize that there's a difference between prednisone and rituximab, for example.
Exactly.
So you can
no, absolutely get a prednisone, like being a systemic corticosteroid, and then certain drug being a chemo that can affect your immune system much more. Talking of complication, and this is something that have been kind of very confused in the population. It's about vaccine, because vaccine are very effective. But what do we know about the benefit of vaccine is like it is for many respiratory vaccine to prevent other respiratory viral infection, is that it often going to prevent the complication, but not necessarily to prevent the infection. And that's why there's been a lot of confusion out there, with some people say, no, I don't want the vaccine. I've seen people having the vaccine and they still had the infection. But what should we have as a key message of who should be receiving the vaccine, and what can we expect in terms of benefit from having the vaccine?
And that's a great point to clarify that sometimes got a little bit muddied in the waters around the time when we really were hoping to see more people vaccinated the universal we, not me specifically. Um, the studies were designed for the COVID-19 vaccine to look at prevention of hospitalizations and death. That was a primary outcome. They never studied in those original trials prevention of infection, prevention of transmission. There was an assumption that if you reduce those bad end up outcomes, that we'd also see those other secondary endpoints, but they weren't there in the trials. So I think it's important for people to recognize that you're getting the vaccine to stop yourself from winding up in the hospital and to stop yourself from dying. When it comes to the other vaccines that are emerging for respiratory diseases, their outcomes are quite different. And I think I just would like the audience to know that whatever you've heard about COVID-19 vaccines, again, they were done well and they were expedited for sure. But you're probably going to start hearing some things about the RSV vaccine, the new pneumococcal vaccine. Those new vaccines were developed under what we would call a more traditional pathway. And have all those extra little outcomes where you can your practitioner can give you more comments about what else to do besides prevent hospitalization and death. But again, when COVID first launched, the biggest problem was we want to make sure we don't lose the whole world to death and hospitalizations. So that was the focus. So I think as long as people realize that they were very effective in preventing hospitalization and mortality, as long as that's your expectation. And then for people who are immunocompromised, I think that's their biggest concern. And so my patients who are immunocompromised are quite interested in continuing to hear that data because they know they're at higher risk and they know they want to do whatever they can to minimize that risk. So it's hoping to make sure that the right conversations are happening between the physician and the patient around managing expectations from these vaccines.
You're perfectly right that the timing in those vaccines came and it may give the impression that things were not done properly, where these studies were following a fast track, but they were really following a very strict methodology, although they were giving approbation in a much faster time. And I still have a hard time to believe that we often blame the pharma industry, but how capable they were to bring that to that level of quality and so quickly. But if we had known COVID 5 years from now or before it came, maybe we would not have had the solution that we had. The timing was very right, that new technology in vaccination allowed the industry to move faster than we would have been able 10 years ago to say something. And the timing was a real issue here, and the quality of the study, they were done under fast track, but those studies were a quality, but they have more limited result in terms of the traditional way of moving on, with treatment, including other vaccine. Are they as effective, these vaccines, that we would see with like the flu vaccine that we recommended for a certain population every fall?
It's a great question. So the flu vaccines, as you know, are seasonal, and they do change the composition every year. Based on, for Canadians, we predict what, again, the universal we, not me, predict what we think is going to be important in Canada based on what's seen in Australia in our summer, which is their winter. So that's where the strains are selected to go into the seasonal flu vaccine. Sometimes we hit the nail on the head and sometimes we get it wrong. There was a year where we missed an H1N1 or something or other serotype. And so we did have a lot of influenza despite having wide uptake of the influenza vaccine, because it is an educated guess as to what should go into it. But for the past few years, we've been able to continue with that 70 to 80% efficacy for the seasonal flu shot. Again, COVID-19 has the additional challenge of the constant mutations and always trying to keep up. Every year, our quote unquote boosters are a different composition from the previous year to try to match what the strains are that are currently circulating, which is why it's sort of evolved into a seasonal vaccination similar to influenza, because it's pretty clear that this is a virus that's going to continue to mutate and cause more strains no matter what we do. And I think the fact that the technology can evolve to match that, as opposed to taking older strains like similar to seasonal flu and just rejigging the influenza vaccine each year after year after year. There's arguments on both sides why one may be superior to the other. But it's just important to realize that seasonal flu and COVID-19, they're not static viruses. So they do have to be adapted year after year to optimize efficacy.
No, thank you, because I think people have to understand that we've been moving from a pandemic to an endemic, and what you described might be what we're going to see in the future, being seasonal. And the fact also that these are alive, those viruses, and they go through mutation thanks to the southern hemisphere, Australia, and so on, that we can use their season to predict our season. But there are more to come in these vaccine, and we may need in the future to have a certain part of the population to have the COVID vaccine on a yearly basis. And other than vaccine, you've been talking about the basic precaution that need to be taken in terms of trying to minimize exposure, being in contact with people that seems to have a respiratory infection. Would you recommend that everyone has received the vaccine, or would you say that your threshold, considering what we know now, should be that certain group of people like the elderly and people that have certain chronic condition, and should really be at minimum the population that we target with our vaccination campaign?
Well, I think certainly the higher your risk factors, the higher your list of comorbidities that could put you at higher risk, and your personal situation and your own desire to go out into the world and still be around grandchildren, etc., who are, tend to be respiratory virus reservoirs, if you will. I think there's a lot of things to take into consideration. I think it's now become a very individualized decision. We haven't had vaccine mandates for quite some time. And I think, but definitely the higher your risks are, probably the more seriously you should take getting these vaccines that can help prevent respiratory infection, because the consequences, whether it be hospitalization, long COVID, just long-term comorbidities. So we've seen exceptional cases of, they don't call it long RSV, but people can get hit really hard if you're over 65 and you pick up an RSV infection, if you have, especially if you have COPD, for example. So I think it's really important to have a conversation with your primary care provider or your respiratory specialist or your immunologist to determine how important it is for you to receive these vaccines.
Yeah, no, I agree. It's a shared decision, and you can only inform patient on what we know now, and our knowledge is evolving as time go, and we don't have necessarily, we have more information, but we don't have all the information. And as time go, hopefully we're going to be able to identify better. But it's always going to be the decision of the patient about the risk that they're willing to take. What about treatment? And if obviously the best way is prevention, when people have the condition, is there any treatment that can be given to stimulate the immune system or to fight the virus? And what do we have available right now?
So in terms of treatment to fight the virus, quote unquote, Paxlovid is still widely available for those patients at higher risks for complications. And I think I'm getting the general sense that while that's what the indication is, that pharmacies are getting a little bit more relaxed about giving it
Okay.
out to more people at risk for moderate disease as opposed to severe disease. The monoclonal antibodies that were so promising, unfortunately, were so specific to the initial strains. So the so-called alpha, basically the original strain, they don't have enough efficacy against Omicron
Okay.
or XBB. So they're not being recommended currently. And then things like when you get the disease, inhaled budesonide has shown benefit. In terms of things that can quote unquote stimulate the immune system, there's really nothing that actually does that in the real world. Like if you have a known immunoglobulin deficiency, you should hopefully already been seen by somebody who's put you on replacement gamma globulin. We know there's anti-COVID antibodies in the current plasma system if you are on replacement immunoglobulin, whether it be through the intravenous route or the subcutaneous route. Again, these are the patients that I see who have either primary or secondary immunodeficiency, and they're on replacement gamma globulin. But in terms of things that quote unquote stimulate the immune response, there's nothing actually that does that per se, other than looking after yourself. Get a good night's sleep, maybe vitamin D. But for the most part, it's a healthy, balanced diet, looking after yourself, don't push yourself, get sleep. All these motherhood statements, when it comes to helping your immune system the best you can, if you don't have a severe problem with your immune system that qualifies for replacement gamma globulin therapy, those are the kinds of things that we tend to recommend to our patients.
Then it sounds like we've done a lot in the area of vaccination, and this is still going on. There is still a lot of research in that area. But in terms of treatment, we've been quite limited. Very limited, like you mentioned, about the monoclonal antibody that unfortunately now the virus has changed and it's not as effective, and they're not to be used as they were at the beginning. Antiviral, but we don't have like really good recognized anti-inflammatory that the people could take to prevent some of these inflammatory storm that has been described in some patients. And it seems that it is an area that would certainly need research, that we will have the choice of more treatment than what is currently available. And I'm always kind of surprised that after many years now, we're still talking of very similar drug and saying that even some of these drugs may not be as effective. Then
Yeah, and the things we thought would make a lot of sense, all the people who make immunoglobulin therapies, they pulled out whenever they could find anti-COVID antibodies from people who were plasma donors. For whatever reason, they didn't work. So maybe you generate antibodies, but they're not neutralizing antibodies. It's a complex area. The things that I was approached to do studies on, it was disappointing, I guess is the easiest way to phrase it. It doesn't mean people still aren't looking, because it's not like COVID-19 has gone away. There's still a lot of granting opportunities for people who are interested in pursuing this area. So who knows what might come around tomorrow or next month or a year from now even.
Dr. Ellis, you're the director of the Environmental Exposure Unit and affiliated to Kingston General Hospital and Queen University. What if you had to say to the public key messages that they have to remember, and also healthcare professional that they should reinforce with their patient, or patient should know about the immune system and COVID? Yeah.
So just by a bit of background, if people don't know, the environmental exposure unit is actually meant to generate symptoms of allergic rhinitis. So we put people into our specialized room, we circulate controlled levels of allergen, people get symptoms of allergic rhinitis, and they sneeze and cough all over each other. So we were shut down during the high points of the pandemic, and we circulated into doing COVID-19 surveillance studies. So what we found in the healthcare population is if you passed all those screening questions, so when you go into the hospital and they ask you, have you had this symptom, that symptom, the other symptom, and then we did PCR testing on those medical students and nursing students. If they passed screening to walk in the door of the hospital, zero of those patients had COVID-19. So asymptomatic screening actually works. So I think my message is, if you fail any of those questions, don't be upset. It's because if you have any of those symptoms, I can't be guaranteed you don't have COVID. Whereas if you have zero symptoms, chances are very good that you don't have COVID. And now we feel comfortable letting people into the hospital if they pass all those screening questions that I know become annoying when you get asked them all the time, every time you walk into the building, but they actually work. So I think that's my main message. From our research that we did with COVID-19, we helped to quell the myth a little bit of asymptomatic carriage and spread. So if you have to answer very rigorous questions about all kinds of symptoms, if the answer is zero to all of them, chances are very good you don't have COVID, and it's okay to go out in public, and it's okay to go to the hospital, etc. And again, obviously, I'm in a hospital situation. We use universal masking as a good precaution. Be tolerant with us when you come in and we ask you to put on a mask, because we know it helps. Because when it's universal, then there's no question that somebody's got a bit of a sneeze or a sniffle and they're just not feeling like they want to put on a mask. When it's mandatory masking, that did make a difference. And it's just because it may be very, very early minor signs, and you can help prevent the spread in the early stages if you have symptoms.
That's very useful, Dr. Ellis.
helps.
And we know that from your clinic, I'm sure in the seasonal allergy, then a lot of patients are sneezing. And from our clinic in RESP, a lot of patients come where they have respiratory symptoms. And you're right that those who don't have symptoms, I think this information you're providing in research have been pretty clear, and it's very useful. Those obviously that have symptoms, it could be for other reason, because those symptoms are not necessarily specific to an infection. And even if it's an infection specific to COVID, there are other respiratory infection. And wearing the mask is really a precaution that need to be taken in the hospital, where you may be in a waiting room or in a crowded environment. I've been traveling a bit in the last year, and I have to say that if you go in the airport, it's crowded, and people seems to have forgotten that COVID was around, and it's still around. And we don't see a lot of people wearing a mask, where you're sitting with stranger, you have no clue and no idea who is around, okay, and why the person next to you is coughing. And then I think, okay, those precautions should probably be a reminder, okay, to people, especially people of a certain age and people that have a chronic condition. Just your final word on what would you see and recommended or research being going in the near future that we have to learn, or hopefully we're going to learn more about the immune system and COVID as a respiratory viral infection, or maybe for other infection in the future?
I think it would be really important to tease out, of all the different layers of immunosuppression / immunodeficiency that I've outlined for you today, what are the real risks of these patients who are sort of in that milder immunocompromised position? We assume that the patients who are on very potent immunosuppressive therapies and or have an underlying primary immunodeficiency, that they're at much higher risk. But I have certain patients who they're on a bucket load of stuff that would have made me think, oh my gosh, if you get COVID, we're done. And they've been able to weather the storm. So I think we need to better tease out exactly what the risks are of each of these different layers. We want to make sure that all of our immunocompromised or immunosuppressed patients are taking all the precautions they need without locking them down forever and ever, amen. So I think that's where we could go. And again, I already spoke to the fact that I would love it if we could have a better understanding of who's actually at risk for this so-called long COVID, because I've seen for some of the patients that I either know of anecdotally because they're somebody else's patient, or they happen to be mine patient. I would love to know, what do I have to, how can I figure out who are those patients who are most at risk? Because it's been quite devastating for some of those people. So I think those are the two biggest unmet needs from my perspective currently.
Thank you very much. This has been very useful. And maybe before we end, or as we ending this discussion, is there any website or place where the patient or the LCAP professional should reach, either in your institution, in Ontario, in other provinces, or at the level of the country, where, because other than asking your physician, obviously that's probably still the best way to go. And but then if people want to access some platform that you can rely on, which wouldn't be Googling, but really platform that make a sense, because they are representing someone or an institution that take a responsibility in providing the right information or what we know. Is there a place that you would recommend?
So, yeah, the resource that I would recommend is the Canadian Immunity Task Force on COVID-19. I was fortunate enough to receive funding from them. I get monthly email updates about the latest findings in COVID-19 research, and because it's not province specific, it's an easy resource for anyone to access. So CITF, or Canadian Immunity Task Force.
Thank you very much, Dr. Ellis, for your time. And I know you have other thing to do. You're in the hospital. I'm sure people had very much appreciated being able to bring that to a language that the population in general can understand, and also to bring that to a lot of LCAP professional that hopefully will be able to better advise and discuss with their patient about the immune system, the population at risk with respiratory viral infection, more specifically to COVID, vaccination, and some of the treatment. And in the doubt for the LCAP professional, it's always better to refer and get information from either a colleague that works more in the area, or a subspecialty in immunology, infectious disease, or other specialty, depending of the condition of the patient. Thank you very much, Dr. Ellis, for your time.
Thank you for having me. It's been a pleasure.
Thanks for listening to the Expand podcast. Stay tuned and listen to other episodes on chroniclungdiseases.com/podcast.